on one of the tweets, and literally dozens of people sent in photos. So these are spontaneous photos sent by anesthesia professionals everywhere around the world of just lookalikes that they wanted everybody to see. So we've kind of put them in a little flip-through slideshow. All of us could come up with the same photo, but it was just interesting, a single little tweet, and all of a sudden, dozens and dozens of these photos kept coming in. So it's kind of cute. Kind of sad.
I was going to say kind of depressing.
Is that on Twitter?
Oh, is that Twitter?
It's on Twitter?
Yeah.
Because I've got one that's not myself.
Yep. So if you go on Twitter and put that in there.
Yeah, I will.
So what was the hashtag looks like?
For ASA?
But no, for this one. So you can find it.
I don't know. I'm going to have to ask her. Yeah. Mike will know. Mike, what's the Twitter that they would find?
What's the hashtag?
Look like drugs that Amy put out. I don't know if Amy's still here, but if you wouldn't mind, just see if that I can find. One last pass, bring them in, what do we got? Okay, well, welcome back. Once again, thank you, everyone, for being here. Sincerely appreciate it. Couple housekeeping items just for folks. If you're going to take the bus that we've arranged, it's probably going to leave at noon, but if that's too tight of a schedule for folks, we can move it a little forward. 11:45 to 11:50, somewhere in there. Does anybody have a really tight schedule where they got to catch a bus? What if you make it like 11:45? I think in 15 minutes, everybody can get out of here, go over, particularly if you happen to check out during the break, or if you've already checked out, and just get your bags out the bus and get those things on there, and we'll have them gunned for 11:45 then, okay? Very good. Let's see. We will end promptly at 11:30, so you can plan on your schedules as you go to get out of here. This morning, we're going to have one session. That session is really an important one. It's implementation of comprehensive perioperative drug safety program, lessons that we can learn from individuals that have already done that. And then the single most important part of the meeting, other than the education and the discussions we had yesterday, are the breakout groups. And we're going to have 4 breakout groups, and I'll announce them after the session's over. But there are going to be 4 breakout groups. One's on drug safety, one is on drug shortages, one's on reducing medication administration errors, and the last one will be on standardizing and innovating. And we have 2 leaders for each group. These groups will be in different parts of the building that I'll point out. And we have not assigned you. Dr. Stoelting, oh, by the way, I talked to Dr. Stoelting this morning. He sent his best wishes along to everybody. He's sitting on the dock down by his home on the lake in southern Indiana and is thrilled that we're here and he's there. Okay, so he says hello to all of you folks. We didn't assign rooms to people. Dr. Stoelting used to often assign topics to folks, and it was random. But what I'd rather have you do is choose the one that you'd like to go to. I mean, you all have different strengths and weaknesses or interests, and choose the one you want to go to. Now, most of the rooms hold 30 people. One of the rooms is small, and it's the one on standardization, only holds 18, unless you want to stand the whole time. But if you go to a room and it's really packed, go to priority 2 and check out that room. And if packed, go to priority 3. But I'm trying to get people to space out on their own, if you would. But if you really have a burning desire to be in that room and you have to stand, well, you can do that too, or pull a chair in from somewhere, okay? So I'll introduce that right after the session. Is there anything else I needed to say ahead of time? I don't think so, other than thank you. So, and obviously I'll be doing that at the end. So let's start session 1. It's implementation of a comprehensive perioperative drug safety program. I'm going to introduce our first speaker, and that's David Bates, who's going to come up. David is a renowned expert in patient safety. He's the editor of the Journal of Patient Safety. He's the chief of the Division of General Medicine and, come on up, Dave, primary care at Brigham and Women's. And David, we're just thrilled to have you here to join a bunch of folks interested in perioperative outcomes.
Thanks so much. Oh, do need the clicker. Great. Well, it's great to be with you. Thanks so much for having me. And I'll be talking about safety overall and then medication safety in the perioperative setting. What should I be pointing at? Say again? Yeah, I'm hitting the arrow at the top. Nothing. There we go. Okay. A few disclosures. Okay. I'm not going to talk about any of these companies, but I do work with a number of companies. So I'm going to start by giving you a little bit of the big picture with medications, looking outside the operating room. Then I will talk about a medication safety study that we did in anesthesia. This is work that was led by Karen Nanji. And then I'll talk about some next steps around in that work. And then I'm going to talk briefly about another study called the Prospect Study, which involved getting patients much more information and trying to get them involved in their care. And then I'll wrap up. Medication errors and safety problems are ubiquitous. This is a study that we did in Massachusetts community hospitals. They're good little community hospitals. We found quite a high rate of adverse drug events in all of them. And roughly 2/3 to 3/4 were preventable. Most of the prior studies had been done in big academic places and had adverse drug event rates that were quite a bit lower than that, maybe 6 per 100 admissions. This slide just shows the proportion of errors that occur at various stages of the medication use process. So 49% are at the ordering stage, 14% at the dispensing stage, 26% at the administration stage, and 11% at the transcription stage. One thing that's made a big difference in medication safety has been computerized decision support. But it doesn't always work so well, and here's some evidence about that. This is work that we did with the Leapfrog group. And what we did is, together with David Klassen and Jane Metzger, we developed a flight simulator. So the way that things work is you put in an order that either killed someone or seriously injured them. And you can see, did your computer system actually catch that? Here's the first data from that. 62 hospitals voluntarily participated. Simulation only detected 53% of the errors that had actually killed someone. So, not really a great performance. Now, the way things work now is when you take this test, we tell you if you missed one of these, and people do put in these checks. There are now 1,500 hospitals that are taking this on an annual basis. Another point is that there was almost no relationship with vendor. People had the notion that if they picked the right vendor, that the medication safety checks would work okay. And that's just not the case. Here's the data by vendor, and you can see that every vendor had performance that was really good, and every vendor had a performance that was not so good. And the point is that the individual institution has to decide which checks to put in place, and that's really important. So I'm from Partners Healthcare in Boston. We had an internally developed computer system for a long time. Then went to Epic in 2015. Where we are now with our medication safety is we're getting one alert for every 2 medication orders, which doctors don't like very much. People are overriding 95% of them. The serious warnings are being overridden at exactly the same rate as the less important ones. And we can't deliver, for technical reasons, some of the clinically most important alerts, like alerts around kidney function. So, we had a very good approach before we made this conversion. We're still in the process of working our way back and putting in place some of the checks. So let's move over to the perioperative side of things. The first big study, at least that we're aware of, that was done using direct observation was done by Alan Mary and colleagues. They looked at 5 operating rooms in New Zealand, found an 11.6% medication error rate using manual record keeping, and then a 9.1% medication error rate using a homegrown electronic anesthesia documentation system. This is the study that I alluded to earlier. It was published in Anesthesiology in 2016. Again, work that was led by Karen Nanji, who is an anesthesiologist at MGH and would be here, except she's about to deliver a baby. In this study, we observed 277 observations, 3,671 medication administrations, found 193 errors and or adverse drug events, so rate of 5.3%. There were 51 adverse drug events, 70 potential adverse drug events. And these rates were quite a bit higher than a lot of people expected, certainly than much of the anesthesia group at MGH expected. We also went through and then looked to see, what things could have prevented these errors. So on the technology front, barcode-assisted anesthesia documentation had a lot of potential. 17% of the medication errors, a quarter of the near misses. Specific drug decision support also had a great deal of potential. So did other types of alerts around things like blood pressure drops and so on. There were a number of process-related things, so assistance with timing of documentations could have been helpful for many things, and all these could apply to more than one, so the numbers, add to more than 100. Another key here was reducing opportunity for workarounds, and then connecting infusions to the most proximal IV port. We're in the process of taking the next step with this, and Karen has gotten a couple of additional grants to actually basically implement many of the changes that we think will make a difference. And we've developed a set of safety-related rules. Probably a number of people in this room were involved in the consensus process around that. And the notion is that these rules will be able to be used in the OR. We're implementing these in EPIC. There are some issues. The way that we're doing it technically is we're building all the rules outside of EPIC and then bringing information back into EPIC. It's much easier to take things out of EPIC than it is to put them back in. So that is the biggest sort of technical issue, but we'll be testing this in a randomized trial. If you look broadly outside of anesthesia, how well have some of the interventions worked? Well, with order entry and clinical decision support, there was a 55% reduction in the ordering error rate. Even with relatively primitive decision support, that number would be higher if you looked at all the things that we have today. For barcoding, there's a 67% reduction in the dispensing error rate. In the administration error rate, a 51% reduction. And in the transcription, in terms of transcription with EMAR, there's a 100% reduction. And I'm hopeful that anesthesia could see some sort of a similar set of levels of reduction going forward. I wanted to tell you very briefly about another study, which is a study that we did recently called the Prospect Study. This is the goal of this study was to try and transform the acute care environment through implementation of a patient-centered intervention. We focused both on patients and on care partners. So not everybody has a healthcare proxy, but almost everybody has someone that they could identify that, for example, would take you in if you needed to have a colonoscopy or have a minor procedure. And those are care partners. We've underutilized them. Here we studied the ICU and oncology units. We had both a patient-facing part of this intervention, and I'll show you that in a minute, and then a provider-facing part of this. And there, what we did was to set up a microblog, which let providers communicate about patients and have conversations both that did involve the patient and that did not involve the patient. The patient-facing part of this looked like this. We gave patients an iPad, and it basically gave them all the information about them in the hospital. We asked them what they wanted. They wanted to know what their drugs were, their labs were, who was on their care team, what was going to happen that day, what their goals were, and so on. So we did all that. We also put in place a dashboard in the ICU around the various checklists that patients have, and of course they have many of them. And providers really like this, and you can look at it very rapidly and see, you know, what's yellow, what's red, what's green, and then drill down on the ones that don't look good. Here's Hermione Granger's patient level dashboard. And you can very quickly see that the issue is she's had a Foley that's been in too long, and that needs to come out. We looked at this in a trial that was published in Critical Care last year, and we found that the overall preventable harm rate fell by about a third. Most of the decrease was around catheter-associated UTIs and pressure ulcers, for reasons that I can't completely explain. But the primary outcome was the overall adverse drug event rate. We also looked at how this affected the way that patients felt about this, and it had a huge effect. So there was a giant increase in the overall hospital rating from 68 to 92%. And in the overall satisfaction score, satisfaction with care, satisfaction with decision-making did not change. And there was also an improvement in the mean global concordance, so whether patients agreed that we were in agreement with them around goals of care. So at the end of the day, I think is as obvious to this audience, anesthesia safety remains an issue. I think medication safety is a particular opportunity now, as many people have brought up, and what we need to do is figure out, you know, how do we get from here to something that really works and fits people's workflow. There's a big need to automate the medication process in the operating room and utilize modern checks around medications. That's especially true for drugs that are in smart pumps and syringes. The electronic health record and these devices ought to be communicating fluidly. And I think this is the key next step in improving anesthesia safety. Einstein said, insanity is doing the same things the same way and expecting different results. We need to change things. Thanks.
Great, thank you, David. Okay, our second speaker this morning is Elliot Grigg. Elliot's an anesthesiologist at Children's Hospital in Seattle, oversees a number of patient safety initiatives up there within that institution. Thank you, Elliot.
Morning. Thanks for having me. I'm really excited to be here. It's been a really interesting experience listening to all these great talks, and it made me think a lot last night as the closer, it sounds like, before we break out in our sessions. What can I really add to this discussion? Because people have already hit on most of the salient points. So I looked back a little bit. I studied art in college because my dad was an artist, and turned out to be kind of a useful way of looking at the universe. I became a doctor because when it became time to rebel, my options were a little bit limited. But I wanted to bring some of that perspective, and I think what I can really provide for us today before we break out into our sessions is really a lot more questions than answers. Sure, we've been through a lot of thinking and doing in Seattle Children's, and I'll go through a couple examples, but I think what's going to be the most helpful is to really sort of think about how are we going to define the problem and get to the next step. And so Rodin, the French sculptor who's got an example here, when he was asked, how does he make such beautiful sculptures? He said, well, I just pick a piece of marble and I chip away all the parts that I don't need. And that's really the theme of the talk today, is how do we distill things down to the essence of what we want to do? Because I think the temptation with a lot of our efforts is to keep adding things to our process. And I'm going to argue that what we need to be doing is the opposite. We need to be taking things away. So how do we get there? I like to do a little thought experiment with my residents. I think there's a lot of baggage that comes in medicine through our apprenticeship model. And so I sit them down in the operating room and I imagine they're a little green alien from outer space and say, what are we really trying to accomplish here? Let's ignore everything we've learned so far and just really go back to first principles and say, what are we really trying to do? When it comes to medications, usually there's some physiologic outcome we want to get to, hypnosis, analgesia, et cetera. And how do we get there? We have an intent. We say, well, I want the patient to be asleep, for example. And there's a lot of steps and processes to get to that next level that we want to get to. And most of the problems, I would argue, in anesthesia, when you look at closed claims and other safety issues, are really about execution. It's rare. It happens that people think incorrectly, but after all the experience and training, usually people think of the right thing to do. But for a variety of reasons, we can't get to what we really want to accomplish. And it's unfortunate that we can't take for granted, once we make a decision, which is usually the hard part, that we can't execute on that 100% of the time. So part of the reason is because it's a really complicated process, and this is just the first piece of it. So John Boyd was a famous pilot during the Korean War who fought in returned to teach the next wave of pilots after he retired and came up with this OODA loop, the Observe, Orient, Decide, Act. Any of you who've done lean training or some of these other things, it's been a little bit commandeered for corporate boardrooms, and you get a much more simplistic model of this. But this is his original model, and I'm not going to walk through all the details. My point here is that every time we make a decision, there's a huge amount that goes into the thinking part. It's very complicated. There are multiple feedback loops. There's a lot of baggage that we carry with us. So what I really want to focus today is on the doing part. So let's, for a second, put aside the decision making, because there's a lot that has to happen there. What we should be able to do is take for granted the second piece, is when we decide to do something, it should happen correctly every single time. So at Seattle Children's a number of years ago, we did a failure mode and effects analysis. Many of you are probably familiar with this process. It's a prospective way of breaking down a task and risk stratifying the failure points within it. And so we found it was a useful exercise. We identified the 5 major steps, which you're all familiar with: prescribe, prepare, dispense, administer, record. But then we broke it down into subtasks and into failure modes. We were able to identify in the blue, you can't read the details, it doesn't really matter, the sub-steps within each step that has to happen for this to go correctly. And most importantly, the yellow, which is all the ways things can go wrong. So every time we gave a single medication, we identified 68 possible failure modes. And we do this multiple times a patient, multiple times a day. It's no wonder we encounter these problems. This is an immensely complicated process. And unfortunately, a lot of these steps rely on accuracy and vigilance, which I find is somewhat ironic as our motto, because it's actually something we're really not designed for. This is not something the human mind is good at. It's estimated, I think we process about 1 gigabyte of visual data a day. And the reason we don't stare at our nose all day long is because our brain is constantly filtering things out for us. And it's unfortunate if we have a system with single point failures that is designed and reliant upon things like vigilance. So this was an interesting study actually at UW back in 1973, looking at the way the workspace is designed for anesthesiologists. And so right here, let's see, there's the patient on the table. We're looking down. This is a bird's eye view. Here's the surgeon. Here's our anesthesiologist. And here's our workspace divided into quadrants. I think there's 2 things that are interesting from this study. One is how much hasn't changed. The basic layout 50 years later is essentially the same. But what has changed? And for me, it's useful. I look at our workspace basically on 2 sides. You've got all the ventilators and gases on one side, and you've got all the meds and IVs on the other side. The right side has gone through a pretty dramatic transformation in the last 50 years. You look at what we've done to the machine design and the way that we've created all these safety mechanisms, and then you look at the left side, not much has happened. Essentially, we're doing, with a few exceptions, things we've been talking about the last day or so, most things are pretty much the same when it comes to drawing up a vial, preparing a syringe, giving it to the patient, et cetera. So anesthesia 101, right? You walk into residency, they give you this book, and the whole first chapter is about how amazing the machine is and all the various mechanisms that we've implemented in order to try to make it safer. There's no chapter on the medication side, right? There's nothing about all the amazing things we've done to make medication safer. And I think there's 2 takeaways I take from this. One, there's been a huge amount of thought and effort and design put into the machine part. The second is the nature of the types of interventions we've created. We've been able to engineer a lot of mistakes away because when you think about the levels of mistake proofing, you think about what types of things are we doing to try to prevent errors. Start here at the bottom. There's a lot of talk today about checklists. I'm a big fan of checklists. I hammer into our residents about how to do them properly and why they're designed the way they are, and they get really bored when I start beating them up about why they have to do it in a specific way and why that matters. But ultimately, at the end of the day, it's not a particularly robust way to prevent problems. It requires a lot of participation and engagement. People have to do it correctly, compliance, et cetera. You start moving up the ladder, you can detect a defect. So those of you who've done lean training, so a defect is different from an error because it happened upstream, but you caught it before it sort of passed along your row in the assembly line. Detecting the error is a little bit better, so that's real time. You detect an error right while it's happening. But still, pretty much anything here down, an error is already occurring, and we're just relying on some mechanism to catch that. What we really want to be working on is how do we eliminate errors entirely? How do we take things out of the system? How do we prevent things from happening in the first place? And that's something we've been able to do a lot on the machine side, but I haven't seen as much on the medication side. So one of the things I worry about when I go to a lot of meetings and discussions about medication error prevention, so we have various mechanisms. I talk about the failure mode and effects analysis, root cause analysis we've talked about. And what I see happening a lot, particularly with the RCAs, and I apologize, I always talk too quickly when I give presentations, is that we end up, because we focus oftentimes on the last worst thing that happened, we end up adding things onto existing processes to try to prevent that from happening in the future. And I usually call this the TSA problem because everyone's been standing in line at the airport. Someday somebody tries to do something terrible with their shoes, and now we have to take off our shoes, and then shampoo, and then et cetera, et cetera. And you keep adding on to an existing complex process, and next thing you know, you've got your lines going out the door because in an attempt to prevent the last thing from happening, you would end up with this very complex process. The other thing I see happening a lot is that we commandeer other pieces of equipment that aren't really designed for medication safety. So one that stands out for me are these smart carts. I think smart carts are great for inventory. I think they're great for controlled substances. I think regulators and pharmacy really likes them, and it's really useful, but they weren't designed for medication safety. Can they be used for that? Sure. But when we pretend like these are really safety tools, we find that it doesn't really fit. Barcodes, I have mixed feelings about. I think they're a really interesting avenue to go down, and we've talked a lot about that in the last few days, but ultimately, they're really designed for documentation. Like when you go to a supermarket, they don't use it to figure out if an orange is an orange, right? They use it to tally up what your inventory is or what your receipt is. Most industries use it to keep track of inventory, but not necessarily to identify things. The machine, on the other hand, does not in nearly as much require compliance. So it doesn't require, if you start handing out coffee cards in order to get people to do things correctly, I start to worry about things like sustainability. Is that really a design that's going to work in the long term? What we need to really be thinking about is how do we remove options, how do we remove errors, and how do we create constraints in a thoughtful way that doesn't impact workflow, but that prevents us from doing bad things. So this is something we actually, our paper just got published online yesterday. It's a little editorial looking at trying to define, and this is still a bit of a work in progress, trying to come up with this conceptual framework, but I found it useful to think about the difference categorizing some of our countermeasures into feedback versus constraints. And constraints we're very familiar with on the machine, right? So you have things like the pin index system, the oxygen nitrous coupling, and various constraints where you can't do things incorrectly. Unfortunately, we don't have as many examples in medication, but just to run through a few. If you think about on the feedback side, so labels themselves, right? They're a form of feedback, essentially. We have to read them, we have to register them, we have to be vigilant about what they say. Color-coded syringes, just for the record, I'm a big fan of color coding as a designer at heart, but ultimately, it's not a perfect system. It's a feedback system. We have to register the color. There's certainly issues that come with that. Even barcodes are essentially a fancy label reader. What I want to focus on are things like constraints. So the guardrails, the hard limits on our pumps, those are much more robust mechanisms that actually prevents you from doing something. Standard concentrations. If you only have one concentration, that's a constraint, but that's something that's going to much simplify your workflow. Pre-filled syringes, I'm a big fan of. Again, another constraint. Bye-bye vials. It's no longer an issue. And so thinking about standard layouts, and I'll go through a couple examples we've done at Seattle Children's. And again, the machine is full of these examples. But thinking about if you're using feedback mechanisms, there's a lot of compliance issues, there's a lot of engagement, they're not as reliable. If we can use thoughtful constraints, they're a much more robust way of fixing problems. So you can eliminate steps and options, you can automate processes, you can physically prevent mistakes if possible. It's not always possible to do something that concrete. There's different types, interfaces, many of which we're familiar with again on the machine. We talked about the NFIT yesterday from the GEDSA folks. We've talked filler keys like diesel and gas in your car. You can't put the wrong pump into the wrong kind of tank. You know, the oxygen nitrous coupling, you can't turn on the nitrous by itself. Segregation, I'll go into a couple examples. And then standardization ultimately is a form of constraint because you're constraining your options, your syringes, your concentrations, maybe the layout of your medications. And the key here is without impacting workflow and decision making. So again, focusing on the execution side of things, not on the decision side. People get very twitchy when I start talking about this. They say, oh, well, you're going to take away my choices. You're going to take away my thinking. You're going to turn us into robots, cookbook medicine, et cetera. That's not what I'm talking about. And that has to do with how you design these constraints carefully. And I think a useful way of thinking about it, a lot of you probably recognize James Reason's Swiss cheese model of mistake proofing. So in his model, the arrow is a mistake. The Swiss cheese is your countermeasures, and if you line up the holes, then something sneaks through your various countermeasures. Personally, I think it's interesting to kind of flip this around and say, well, what if the arrow was what you're trying to do, and now you've prevented sort of everything else from happening, and all you can do is really go right down the middle, and the only option you have is to do the right thing. And how do we get to there? So a couple examples. These are not sort of the end-all of medication safety, but I think they help illustrate a couple of the concepts I'm talking about. So at Seattle Children's, when I started a number of years ago, we had this big tray just sitting in the drawer. It had lots of options. It was in no particular order. It was alphabetized because that was easier for restocking afterwards, but not necessarily for using it. We had high and low use things together, high and low risks. And then, of course, we've talked a lot about the sort of parade of different colored vials that show up, and that gets very confusing. And we said this is clearly not a safe way to do it. There's too many choices. There's too many ways for this to go wrong. So what we decided to do was to split into two trays. And so we have a primary tray at the top and a secondary tray at the bottom. And so I work at a pediatric institution, so we have a lot of different options and sizes. But if you do an LMA anesthetic in an adolescent, then essentially you use everything in this tray and you don't need anything else other than controlled substances because those are managed differently for security reasons. But the idea being that we would match our medication selection with exactly what we need and not have anything superfluous. So what we discovered after we did this was that 85% of the cases in our hospital, that's the only tray we need to use. And what that means is that 85% of the time, these are not accessed at all. So we've segregated our medications in such a way, so we had issues with muscle relaxants being confused with antibiotics was a big one. We had people drawing up little vials of vasopressors and various problems. So once we divided these into two separate areas, then we found the vast majority of the time, nobody would even open this tray, and consequently, you couldn't confuse some of the things in here with what's in here. And we also were able to go from 22 meds, as you can see, down to about 16 when we decided what we really need to work with on a daily basis. So simplifying, separating, and then using multiple signifiers. So I'm in the camp of the nuclear power industry, which is the more the merrier when it comes to ways to identify things. So you want color, you want shape, you want size, you want location, you want all sorts of various things, because you need to really use as much as you can rather than expecting everyone to read a black and white label, which I think is not a great idea. So pre-filled syringes, I can't really emphasize enough. I think pre-filled syringes are just a beautiful, and I don't really care who they come from, but I think are really an elegant example of what I'm trying to illustrate here. So again, back to our failure mode and effects analysis, all these steps, all these various things that can go wrong. If you add in pre-filled syringes, you basically remove an entire section of the problem. So all the effort and issues you have with preparing vials and labeling and making sure the concentrations and everything, that completely disappears. And that is an enormously powerful way of just eliminating a huge variety of potential problems that you can have. And this is, again, an example of level 1 mistake proofing. So you've just removed the possibility of even having all these errors. So then the question is, how do you get into some of these others? So when I started at Children's, I just went around as an experiment and took pictures of people's workspaces and was pretty horrified. I often use the standard of my wife, who's not medical, And so I just explained to her pretty simply, oh, here's what I do. So I take this vial out of this drawer with all this stuff, and I hand draw the label. And I mean, it's horrifying if you think from like a patient perspective, like, really? This is where people find their life-saving medications in this pile of rubble here? So what we did was we decided we really need to clean this up. We need to standardize this. This is a huge risk. So we made a template that we put on the top of all of our carts. So now if you walk into any anesthetizing location from OR to radiology to GI, every single medication layout is exactly the same throughout our institution. And again, I guess I'm big into the S's. So a couple themes here. Simplification. So we really wanted to simplify the layout. We really wanted to standardize across the organization. We wanted to separate things that are bad, that get confused, and so you try to segregate things. Multiple signifiers, so we've got the location, we've got the, you can't really tell, but our emergency meds are elevated on a platform, so that's another way. We have these wells where things physically can't be put in incorrectly because they only fit in one direction. It's not a particularly elaborate or sophisticated solution, but the one thing I would mention is that it looks very simple. This took about 6 years to make it this simple. And this goes back to the Rodin process of chipping away at what you don't need. The first 6 versions of this were vastly more complicated and had all these options, and everyone tried to hang an ornament on the Christmas tree and be like, oh, let me add this and this and this. That's the easy thing to do. A lot of what good design is about removing everything you don't need, and oftentimes that's much more difficult. So the takeaways from the talk here. So I think if we really think hard about how we design our workspace, it'll have a huge impact on how we reduce medication errors. I don't want to impact the thinking part. I think there's plenty to do for us as far as decision making, as far as experience. What I want to do is streamline the doing part. Once we decide to do something, we should be able to take for granted that it's going to happen correctly in the way we intended every time. And I think the way we do that is we simplify the execution, we standardize options and interfaces, and we put in thoughtful constraints. There are certainly ways to put in constraints that people can't do their job correctly. A big part of our medication template was leaving half of it flexible, right? This was a big design decision. Bottom half, knock yourself out, do whatever you want. Because if we go crazy and start constraining every single little piece, it's not going to work. So you have to be thoughtful when you put in constraints. And one last thing I wanted to mention, we really have a unique workflow, and people have talked about this, how we're the only ones, and there's no one else looking out for us, and we don't have CPOE and pharmacy and whatnot. And a lot of us look at that as a liability because we don't have all the safety mechanisms of other parts of the hospital. I really see it as a unique opportunity. Because we have control over this entire medication cycle, I think we have an opportunity to really rethink the way we do it. We don't have all these other players we have to worry about. And so I have this vision, and this is what my research is going to be hopefully in the next couple of years, is coming up with some sort of concept. This is a coffee machine. But this conceptually, how do we make it automatic? How do you push a button and it happens correctly every time and you can't make mistakes? And I think what, ISMP may think we're a small slice of the pie. What I really want to see our specialty doing is becoming leaders again, like we did in the ventilation and the gas part of things. I think we should be the ones setting the standard for the rest of the hospital rather than us borrowing barcodes and 2-provider checks and various things from everybody else. And I think what I sort of think about late at night is these subtractive questions. So how do we take things out of the system? How do we really simplify things? I don't have all the answers. Some of them are easy. So how do we eliminate vials? Well, pre-filled syringes, we already know that. But when you get down the list, it gets a little more complicated. So how do we eliminate syringes? Like maybe syringes aren't the right answer. How do we get rid of labels? Is that barcoding and RFID? Ways that we don't have to rely on reading these things anymore. Mental calculation, I think, is a huge risk, especially working in pediatrics. And there's a whole litany of things. So I think eliminating and automating are really the 2 themes I want to leave you with. And again, I don't necessarily have all the answers, but I think conceptually, if we think about how to simplify, how to subtract, and how to really design down to the essence of what we want to accomplish, I think it's going to make what we do much more reliable and much safer. Thank you.
David, you want to come up? Okay. So we kept this relatively short, so number one, we have more time for questions and answers, and also because we want to get out to the breakout groups. But 2 terrific talks this morning. How about folks going up to the microphone with questions? Okay, Andy.
Hey, got a couple comments and questions. Non-G. So I've been in the business of studying drug error for a few years, and of course, as soon as that non-G paper came out, we dissected it pretty thoroughly, very interesting. And as you mentioned, it got results that were appeared somewhat different from results that had been obtained by a number of previous investigators. We were frustrated by that paper because we couldn't figure out from the information given in the paper what the definition of drug error was. And drug errors included as diverse things as a blood pressure less than a mean of 55 that was untreated for 10 minutes or something like that, which I think many people in this room would not even regard as an error, let alone a drug error. A syringe of a controlled substance left unattended on a cart top, drug error. There was also not a really comprehensive list of what was measured. In other words, it wasn't really stated what was an error, what was counted as an error. And then there was no, what we were really hoping for was an appendix, which would have an exhaustive list of every single error that was measured in the study. So I would just like to encourage the people at Harvard, if they're continuing this kind of work, to define error, because I think there's a wide variety of definitions of anesthesia drug error. I think it's very important to define what you're measuring and then to report what you've found, and not just say we found a lot of errors, but to tell us exactly what those errors were, exhaustively. And I wrote this in a letter to the editor of Anesthesiology. It was published. But since you're here today, I realized I had an opportunity to badger you with this.
You're doing a remarkably good job of
Thank
hiding
you.
that fact.
We did respond to your letter. I remember getting it.
Yeah, good. So we don't need to continue that debate here, but I'm sorry, I couldn't resist the opportunity. For Dr. Grigg, I just wanted to add a couple of pieces of unpublished data in respect to his comments. So there was Ellie, you made sort of a slightly negative comment about checklists, and we love checklists. We believe in checklists. And a couple of years ago, we got a grant from the APSF to examine the efficacy of the APSF's pre-anesthesia checklist. So we completed that work, and it's under review, and we had a sort of a misfire with anesthesia and analgesia review, which I won't get into. It's an ugly tale. But that work is still under review, but we showed a significant reduction in anesthesia adverse events when that checklist was completed. So I think there's evidence that checklists are effective, and we love checklists, and we have a ton of them, and we're getting more. Coffee cards. So that was obviously directed at me. It's fine, I don't take it personally. And the sustainability, so I
Andy,
think that
did you have any
providers.
coffee this morning, I hope?
Yeah. So I'm trying to shorten this.
Thank you.
And it's not a tirade, but I can't control myself. So I think it's important, and I've talked to a number of other people at this meeting about the use of incentives to get providers to implement safety measures. And I think it's a useful tool that shouldn't be overlooked. And just for the record, our barcode scanning behavior is sustainable after the interventions that we've done with coffee cards and reporting data into individual providers and so on. So, and eventually we'll publish that. I mean, we have a paper in that's been accepted for publication in anesthesia and analgesia with some of this data. We've done it for long enough now that we have sustainability data, and it is sustainable. The other thing, barcoding. So,
Andy, can I just, do you have any
Yeah.
questions for these guys?
No.
Well, I thank you, Andy.
Hi, Jan Aaronworth. Well, I understand your enthusiasm for pre-filled syringes, but I know Barker has said that he's the curmudgeon of the group, but I'm probably number two. So my theory is that there's nothing that's idiot-proof because idiots are smarter than us. So if you have someone doing a pre-filled syringe, so let's say it's your hospital pharmacy. So someone makes an error there, and please don't say they can't make an error. So now you've got 100 syringes that are incorrect instead of 1. If it's a compounding pharmacy, you may have 10,000 syringes that are misfilled or had the wrong dose. So the first question is, how do we know, or where's the safety checks, or how do we know that these pre-filled syringes that I'm getting actually have, 100 mics per cc of phenylephrine? I mean, that's what bothers me. I mean, I trust myself a little bit more than I trust someone making 100 of these syringes.
So,
So Joyce says is they pull lots out and test them. Joyce, we have individuals in this room from industry that can tell you that what Jan says is correct. They do have errors in their lots that are unrecognized. I can tell you, I won't get into it, but there are people in this room where drug has come to Mayo Clinic and pre-filled syringes that's inaccurate. It's the wrong drug in the wrong syringe. So I support Jan on this.
But you also trust what's in the vial, right? Yeah. So there are measures in place to test
Yeah,
those
also comes down to the vial. It comes down to, yeah,
Right.
correct.
I just wanted to make that comment.
Yep, nope, correct.
yeah, I mean, I think these issues can happen anywhere. There was a really interesting poster, and I unfortunately don't remember who did it, but years ago, I still remember at ASA talking about how an institution got a big pharmacy robot, and they were excited that that was going to remove all issues with medication preparation. But their experience was what ended up happening was they essentially took who was involved in actually putting the medication into the machine, sort of went down the hierarchy until you basically had like the UPS guy just kind of plugging it in for you. And so and then they ended up with a whole syringe, I think it was lidocaine filled with vecuronium or something. So I agree that nothing's perfect. Personally, I think if you can standardize at an industry-wide level in some lean and safe way in a warehouse where people are doing the exact same assembly line day after day after day, that's probably more reliable than a bunch of random people in a stressful operating room doing it under the cover of darkness in the middle of the night, having been sleep deprived, et cetera, et cetera. So I think there still are arguments. Yes, there's this trust issue in terms of like, I'm better than everyone else, which a lot of us carry with us. I think the vials have that problem, the syringes have that problem. I think what I'm most concerned about is in terms of we may trust ourselves, but the fact that so much of what we do now in the OR is manual, requires all these multiple steps, is done under less than ideal conditions, to say the least. That worries me more than in terms of what happens in a warehouse. I mean, at some point, we have to trust the supply. I'm not manufacturing these drugs myself. Some point I have to trust.
I think the drug, when you get it in an ampule, I think that's fairly trustworthy. What I'm concerned is who's taking and making that dilution, and that's more concerning to me. So they take, a milligram of phenylephrine and turn it into 100 mics per cc in a 10 cc syringe. So doing that properly over and over and over again is more concerning to me. And the second point is just a practical one, in that you can put 10 amps of phenylephrine in a slot, and that you can only put 2 syringes in, 2 pre-filled syringes, and our carts have a finite amount of space. And so when you get in these cases where I need more than 2 syringes of phenylephrine, now I'm really scrambling. Where do I find it? How do I get it? Who's going to run to the satellite pharmacy or wherever you're storing it to get more? I think that's, just a practical concern. We don't have a big enough drug cart, big enough supply cart to put, 20 pre-filled syringes of every drug we use. So I don't know if you've thought of, peds may be a little better, easier, because you don't use the same doses as an adult. So do you have any, when you were designing your stuff, thoughts about that?
Yeah, I mean, I think every change is going to have consequences. I think there are certainly, as you fix problems, you introduce new challenges. But, I mean, again, I would go back to, I think finding space for syringes is probably less of a safety issue than having people drawing up phenylephrine. You know, I work at a big academic center where we've got residents and fellows and CRNAs and 1 million people. And in addition to this sort of idealized state of the single provider doing what they want, we also have 10 different people running in and out with lunch breaks and whatnot. And so my biggest concern is the more we do manually and the more mental math we do, I think the more risk it introduces. And so I would rather solve an inventory problem than trying to work on people's
Right,
mental
so but
math.
practically what do you do? When
Jan,
you,
it'll vary from institution to institution.
All right.
I'm absolutely positive. Ian?
And can I just make one other comment? There are technologies that are becoming available or are likely to become available soon that let us identify what compound is in a solution and what the concentration is, and that would be really helpful.
Yeah, let me expand on that a little bit. So I have a sister-in-law who's a vice president for Coca-Cola for quality, and they get over 100,000 aliquots of Coca-Cola products. There are 286 Coca-Cola products, Dasani water up to Coca-Cola, from around the world every day are shipped in by FedEx. And so they have to test all 100,000 aliquots every day. Every single Coke product, 286 of them, have a unique marker inside, and they just scan them. And they know exactly which product it is. Is it a Coke product, and which one is it? And if it's not a Coke product, well, then their lawyers go after that place they collected it. But why can't we do that with our drugs? We don't have many drugs. It'd be easy to put markers. I mean, easy, I'm not a chemist, I don't know. But theoretically, if Coke can do it, our pharmaceutical companies could do it, why can't we scan every drug before we go? You know exactly what it is at that point. So,
good point.
yeah. Okay, Ian?
I'm appointing you an ASA Coke representative.
Thank you, Jen.
Hi, Ian Black with the Denver VA. This is a design question based with the subtractive sort of thought process. So a lot of the work about defect versus error is based on early 1900 sort of industrial models. There are some people now in safety who are saying that when you reduce the defect, you reduce the signal in the system that makes people sort of catch things. So that's why BMW is re-engineering back their throttles so you have a feel, so it's not quiet. That's why sometimes having your resident not set up the suction and then they find, oh, the suction isn't set up, actually primes them to avoid some of the catastrophic errors. So I'm curious how much thought process was put in about removing all defects, because that may lead to a higher incidence of catastrophic error.
Well, yeah, it gets a little conceptual, but I think leaving defects in order to kind of keep people on their toes is probably not the best way to do it. I think what I've been trying to talk about is rather trying to make it so that we can't create certain defects, so you can't pour sevoflurane into an ISO vaporizer anymore because you can't physically fit it in there. And I think it's things like that that are useful. I don't think it's useful to sort of teach the residents about vapor pressures because, oops, they put the wrong one in.
Catastrophic,
yeah.
low-level defects, there is some evidence that low-level defects actually improve the safety of the system.
Yeah, I think it would be hard in the anesthesia. I think it's an interesting concept. I don't know specifically. I don't think it's been studied in anesthesia that I'm aware of. And I think given the stakes of what we're doing, I think it's tricky. I think it's an interesting point. To be honest, I don't really have a great answer for you.
Ian, I can see a great VA grant coming out of that.
Jim Phillip, Brigham and Women's Hospital, Harvard Medical School. Many years ago, we had technologists filling some of our syringes before the days of pharmacy taking an active role. And we had the swap of succinylcholine 1 cc in syringes that should have been Curare to block fasciculations. Because the first anesthesiologist discovered the problem of the patient fasciculating, actually it was the second anesthesiologist, we rapidly ran from room to room telling everyone not to use that. And I wondered if one finds a defect in a drug, if there are good communication techniques for a department, now we would do it by paging, and how we can solve that. And also the other question is, do we put enough support in our hospital pharmacy in the operating room to deliver those extra drugs that Jan Aaronworth was worried about? We have trouble. They've dropped their number of assistants running to rooms to bring extra things. How do we help them increase their resources?
Yeah, I mean, again, I think there's this issue in terms of who's preparing and where does it come from, and no system's perfect. And I think we like the idea, we sort of romanticize the idea that if we at least have ownership of it and we have a certain audit trail in terms of what we've been doing, that at least we're the one making the mistakes. I think we still do make a lot of mistakes as part of the problem. Certainly there are bad ways to do this where we outsource it and it's not effective and we're not resourced, and so we don't want to do it poorly, but I think the idea being that our current state of what we're doing, even if we have ownership of it, it's not particularly reliable. So again, I think there are certainly circumstances, and we're more sensitive to if somebody else makes a mistake. We somehow are more comfortable whether if we do it or a resident does it, but God forbid a tech does it somewhere else, and then it's much worse. But I agree. I mean, no system's going to be perfect, so you do need a way to communicate if there's an issue. Certainly this poster I mentioned where somebody had a VEC and all these lidocaine syringes, like they had to run around and tell everybody, like, stop using lidocaine because nobody's waking up. Again, I think these are solvable problems. I think certainly you need resources in order to adequately staff some of these other places you're going to be doing some of this med preparation. There are going to be new risks and new problems, but I don't think doing everything ourselves by hand in the operating room with math in our head is a great way to do it either.
I'm going to ask David to address that just a little differently. And David, you're in a leadership role of a large institution. When you hear about these type of things where resource constraint might play a role, what do you advocate for, or how do you go about doing that in a large institution?
Yeah, I think that's a struggle. I don't know that most institutions are doing a great job around that. I mean, what we try to do is figure out, how big an issue the particular one is, and then how that fits with our other resource constraints. And I can't say that I feel like we always end up with the most rational of answers around doing that.
Okay. Steve?
Steve Greenman from Chicago. Thank you both for presenting. I particularly applaud you for looking at the anesthesia cart and figuring out a better design. I think we all have to look at that. Going back to the phenylephrine comment, I think limiting the amount of phenylephrine syringes is an excellent idea, because how many of you use more than 2 whole syringes of phenylephrine in a general case that you're involved with on a daily basis? Raise your hand. More than 2. So after 2 syringes, we should be thinking about what else is going on. And maybe by having just 2 syringes or even 1, we'll think about it, and it will allow us to figure out what actually is going on with the patient, rather than continually giving syringes and syringes or drawing up more phenylephrine to treat a blood pressure and not actually the patient or the underlying condition. So maybe this is another way to figure out how to best treat patients. So I applaud you for doing this. I think we should look at streamlining these carts and maybe standardizing them even more than we do now to limit the amount of unnecessary overloading amount of dangerous drugs. So thank you.
Matt?
Matt Weinger, Vanderbilt. I couldn't let the small defects comment go unchallenged. So it's certainly true that we learn from our errors, and so in order to become experts, we have to experience some errors. But how many of you want to be patients in situations where the provider is learning from their errors? That's what simulation is for. And we also know from the literature that small defects are not benign. So a small defect represents a system failure mode that in another circumstance will lead to harm. So we want to get as many of the defects out of our systems as possible, period. However, it is unlikely in any of our lifetimes that anesthesia care is going to be Six Sigma. It's just too complicated, too many humans in the loop, and humans are invariably going to make errors. And so what we need to adopt is what other industries are now calling Safety 2.0, which is don't just learn from failures, learn from success. So some of us are starting to study how do systems like Elliott's system, how did they make things safer, and what can we learn from that? So I applaud your work.
Thank you, Matt. A lot of comments.
Well, yeah, and I would just add, I thought about it. I think one of the issues is that, what makes a defect small, and a lot of it's just the context and the circumstances, and you often don't know until after the fact, because certain things that start small, once they get through a whole process, can turn into something dramatic, and it's hard to predict which is which, and I think we only find out in retrospect. So I think it's still a reasonable goal to try to eliminate as many as possible, particularly given that we're never going to get to zero.
Oh, Ian, go to the mic, please.
While you're walking up there, let me just make another comment that I wanted to fit in. This is a complicated issue, and I don't know what the right answer is. Radiation oncology is another discipline that has very high levels of safety, but it's clear that can lead to complacency. People are so convinced that the machine is correct and so forth. There are a number of examples in which, say, 4 people got way too much radiation because they just believed that the machine, had to be correct. And I believe in eliminating the small defects as Matt suggested, but once you get to high levels of safety, it does get complicated.
No.
Actually, I wanted to embroider on that. It's Baron Metz from Penn State. Yesterday we had a presentation on the fact that some infusion pumps might not actually work, and that the first thing you should do is turn down the clamp and then check it out. And in this era where we expect everything to work, so you get a new BMW, you don't expect it not to work. Whereas 35 years ago, you got into a car and it broke down and you expected it to break down. So now what we're having is that we're training our residents in situations where they expect everything to work. And they don't really think that it's not working properly. So how do we train our future colleagues to realize that things are not defect-free, and we actually have to start worrying about the fact that it might not actually work? I'd love your observations on that.
I mean, I think that's an excellent point. My thoughts are that some of that can be handled in simulation, as Matt was suggesting. I think everybody should be going through some simulation and trying to figure out scenarios which are like that. And that's probably the safest place to do that. It still doesn't fully prepare you for the real world where I agree, people fall into this particular trap.
I have a follow-up question, a different question actually. We talked a lot about when we get concerned about a certain drug not being the right drug, or not being the right concentration, or not having the right efficacy. So you hear this as a chair sometimes in a department. People say the propofol isn't working. For the experts are saying the usual dose is not having the same effect. What is your recommendation we do if we have such a warning from faculty or others in the department? So it's not an incorrect drug, but there's a concern that maybe the strength isn't actually right. What is the next step that we should take?
I think someone should do an evaluation. Your pharmacy can probably help you with that.
But what do they actually do?
It varies from preparation to preparation and so forth. Some of the pharmacists in the room might want to help me out. Yeah.
I think Deb's going to
Please
do
tell
that.
us.
And then, Tim, you'll be the last question. Okay.
I guess it pays to know Tim well because I get a cut in line. So just some comments back to the gentleman just spoke. So what the pharmacy can do, if you think that there is an error, as Dr. Warner said, there are ways of actually testing the drug to see, is it the drug that you thought it was? Is it in the concentration that you thought it was? So as a person who has unfortunately been through numerous RCA processes, that's always been something that we have to look at. If any of you know the Emily Jerry story, they tested the bag to realize the technician had used concentrated sodium chloride instead of 0.9%. So that was essentially the root cause of the problem that transpired to her death. So there are ways that we can do this. The gentleman who spoke up to talk about resources within the pharmacy, thank you, by the way. We are at this conference because we want to partner with you. We are not perfect, but none of us in this room are perfect. So we have to do this together. And there are times where I would actually choose to have a pharmacy technician make something versus myself, because now I have two people in the process and I can check what they were doing. As a pharmacist of switching mindset, and I'd be very curious to hear both of your comments about this, I initially as a pharmacist learned of, the product comes out and I'm checking something and I'm already kind of making that assumption in my mind that what I'm checking is right. There was a time where I changed my thinking as a pharmacist, and everything that put in front of me, I was going to assume that it was wrong, and I had to prove to myself before it went out that pharmacy door that it was right. So I think there is a way of changing our mindset with our students and residents and so forth about looking at it in a different mechanism, and that you really have to go through the steps to justify that this is dopamine and I'm sending dopamine out of the door 1 milligram per mil. So.
Any comment? Or, yes. Just keep in mind, folks, your 15-minute break is shrinking. So here, hold it.
Yep.
Steve, can you turn this on?
Just to add to what Deb just said, there are a lot of mechanisms within your institutions that actually do concentrations of drugs, right? So anti-10A levels, things like that. I would encourage you to actually partner with your lab, and usually what they can do is set up assays, HPLC assays, to actually quantify and test the drugs internally in your health system without sending them to an outsourced lab, which will charge you a lot of money to do these concentrations. So most hospitals have already some capacity to do drug levels, right? Because we do antibiotics, we do TACRO levels for chemo drugs. So you just need to really kind of pair with them and give them, the list of drugs, let them set up the assays, and then you can have an internal process to do it yourself.
And then I'm just going to make one final comment. This is just as an awareness for the room. Pre-filled syringes. I think that they are great. They're ready to administer. We're starting to see more of this. I'm just going to give the caveat, if we go down this road, if you have a pre-filled syringe and you decide to throw it on a pump, please be aware that not all IV syringes are approved to go on a device. BD has a list of approved syringes, not approved syringes. So if you receive something in a syringe and you think you're just going to throw it on your syringe pump and go, please be aware that there are not standards around those syringes. So I've already tagged Dr. Brown that the FDA should look into that, but I just wanted to put it out there as a safety note if you're going to be using syringes. Thanks.
Okay. Baron, did you have another comment?
No.
Okay. Tim, you're the last one.
I don't want to stand in the way of the break, but Dave, you mentioned that 95% of the alerts from Epic for the physicians when they are doing their orders, that 95% of those are just blown right through, right? Kind of reminds me of the early days of smart pumps with blowing right through the soft limits. But one of the things that, if you fast forward and if anesthesia does what's being done in the rest of the hospital and the 400 or so hospitals that are doing interoperability, there's a good chance that there are going to be alerts for the anesthesiologist as well. And it seems like as we're getting these large EHR programs, it's pretty much a canned deal. I know you used to have your own and you had a very high compliance with the alerts. Any thoughts about that from the standpoint of going forward?
I would just encourage the profession to take the bull by the horns around this and come up with your own list. You'll be better off than if you use some of the canned things. And we're going to be able to turn off most of these unnecessary ones, but it has been vastly less pleasant and more difficult than I expected it would be. And it's just it's taking a long time. It's now 3 years later, and we're still showing just far too many.
You really do find out which ones matter over time, because if they're being canceled out 98% of the time, probably didn't matter a whole lot. But anyhow, folks, we got a break. You get you get 15 minutes. Now, the rooms you go to. Some of you folks weren't in the room when we started earlier. So there are 4 groups of interest. the Drug Safety Group, led by Dave Goodell and Rich Prelip. The Drug Shortage Group, led by Steve Greenberg and Jerry Cohen. The Reducing Medication and Administration Errors, led by Megan Lane Fall and Lynn Reed. And Standardization and Innovation Group, led by Jeff Feldman, Tim Vanderveen, and Patty Riley. Now, you're not assigned any of them. Dr. Stoelting used to often assign you. You had like a number on the back of your card, or it was in the list. You can go to any of them you want. If the room is full, most of these rooms hold 30 people. If it's full, go to Plan B, and because all these are of interest to most of us. And just let's not have 90 people show up in one room and 3 in another. So try to balance them out. The rooms are the Cervante room. Now, Cervante is where we had the lunch line yesterday. Cervante is the one to the north. There are 3 rooms there. There's Cervante, Palmera North, and Palmera South. So Cervante is the Drug Safety Group. Okay, so Dave Goodell and Rich Prelip. Palmera North, which is the one right in between those 3, again, right behind where you had lunch line yesterday, is the Drug Shortage Group, and that's Steve Greenberg and Jerry Cohen. Reducing Medication Administration Error Group, that's the Palmera South, so to the south, to the right as you're looking directly at the door there, and that's led by Megan Lane Fall and Lynn Reed. And then the Standardization Innovation Group, if you want to get away from the crowd, it's a small room, holds 18 people. It's the board room, right where you went to check in, you come out, and it's right across the hall. So way over here, it's kind of a pretty area, quiet. If you're interested in the Standardization and Innovation Group, that's a good place to go, and that's Jeff Feldman, Tim Vanderveen, and Patty Riley. By the way, if anybody left a sports coat or a suit coat, Stacy has it for you out there. You already got it? Okay, thanks. And then what we're going to do, I'm going to ask each group to come up with 4 recommendations, okay? But I want them prioritized. One's your biggest priority on down to 4, because eventually we come back in, we're probably going to try to get down to a dozen between 4 groups, and let's see what we can do with that. And we'll leave here, and then remember, when we leave here, over the next month or 2, we're going to be putting work groups on, and some of you folks, I have all your email addresses. Some of you folks are going to be asked to, if you'd like to, participate in those groups on how do we actually get these recommendations implemented. And because we're going to get that ball over the goal line on these recommendations, okay? That's the key. So your work's not done when you're here. Remember, this is not an education meeting. This is a consensus conference. And when you come, we don't charge you a penny. Well, other than you have to pay your airfare, but no registration. But you don't get anything in return except you deliver your expertise to APSF so we can do this together. And we're really thrilled you're doing that, and thank you so much for doing that. So I'll see you back here. The breakout rooms will start in about 10 minutes now, since I've talked too long. And we'll be back in here, I believe, at 10:15. There is a snack from 10 o'clock to 10:15, by the way.